Thanks, everyone. So a couple years ago, we tried something we had a lot of different people wanting to talk about a particular topic, Zika, a couple years ago, and came up with the idea of having a panel sort of talking at it from a couple of different angles. And it really worked well, and so we've kind of settled on this as a format to share ideas. And the planning group this year was sort of battling around topics because there's so many compelling things that are facing us now with the opioid epidemic, with the emergence of antimicrobial resistance, and trying to settle on things eventually ended up with a stalemate. And so we actually came up with this idea of doing something that was really around the judicious use of medications. I think we're beneficiaries of great discoveries around medications, and we face initially, especially in less resourced areas, the challenges of access and trying to get those medications out to people. And certainly people that work in palliative care struggled for many years to get opiates to be available for people that were in the end stages of life. Now we've seen the opposite of that, as we've seen this opioid epidemic emerging in our country and now in other countries as well. So we really had this idea and thought we could assemble a group of experts that could talk about, from different perspectives, the use and misuse of medications as we go forward in the next few years. So I will see if I can simultaneously do three things at once here. So first off, I'm going to introduce, so basically what the format's going to be, each of our speakers is going to give 5 or so minutes of comments. That's a very loose 5 minutes for those of you trying to keep score, around their topic, and then we're going to open it up for questions and try to make this kind of a free-flowing discussion. So first up is going to be Trisha Ranola. She's a graduate of the UW School of Pharmacy here in Madison. I won't say what year she graduated. And she completed her residency training at the VA here, at the Middleton VA. And she's currently a member of the home-based primary care interdisciplinary team at the Middleton VA clinic. And she provides chronic care and longitudinal care for chronic disease states and medication for veterans. So she's really intimately, I think, in the weeds with a lot of these issues. She's a preceptor for many students, residents, and has worked with many of our Global Health group. And so we're really appreciative of her roles in sharing information and her role in heading up the Global Health programs at the School of Pharmacy. So Trisha, you're up first. Let me sit in your seat.
Thank you. Thank you for that introduction. I'm going to be spending the next 5 loose minutes talking to you about a medication, an issue called falsified or counterfeit medications. So this is something that's probably very familiar to most of you, and hopefully you can gain a little bit of knowledge from my 5-minute overview of a very broad and deep topic. So first, I just really like to go through testing your knowledge. I always put this slide up here because I want to see if you can find the differences between these medications. The top line is gabapentin. The next one down is amlodipine, and the next one is donepezil. Can you spot the differences and tell which one is fake? Right? This is what we're working with. These are all medications that were found in the US supply chain. And they're all made on this very compact machine here that's collapsible, and you can move it around the world at a whim. So if you are an entrepreneur and like to make some more money, you can invest in one of these machines, kick out 500,000 tablets a day, get some packaging that you found at a local pharmacy or hospital, repackage them, and make some pretty good money off of this. Here's another example that was in the United States supply chain in 2012 and 2013. Many of you may be familiar with this. It's a medication called Avastin. It's used in cancer. It's a cancer therapy, as well as a therapy for intraocular hypertension. So this is a medication that was sold directly to physicians in their office through a legitimate distributor from Canada, but not a distributor that was recognized here in the United States. And after the FDA did some research, they found out that it actually wasn't the distributor that they thought it was from Canada. It's not legal in the United States, and all 48 states were affected by this medication. It was a fake medication, no active ingredient. Think of all the lives that were touched by this medicine. 48 states were purchasing this medication direct to physicians and offices. The person who was in charge of distributing this medication was given a 6-month house arrest and 5 years probation. So really a slap on the wrist for something that could have been devastating to many, many patients. How does this happen? Well, one of the reasons why it's really an ongoing global issue is that we don't have any clear consensus on definitions. Right now in the United States, the definition of counterfeit medication applies to intellectual property issues. So it's very much a white collar, it's a crime of opportunity for intellectual property issues, but does not have any definition relating to public health. That's different around the world, as I mentioned. There's not a clear consensus about what is a counterfeit medication. So this article back in 2012, it's a little dated now, but I continue to use it because the issues still have not been resolved. So these issues of having a clear consensus as to what is a falsified medication, what's a counterfeit medication have not been resolved. This article is really, really good if anyone is interested in looking at this. It really draws attention to these issues of public health and intellectual property rights, and how do we gain consensus on that in a global fashion. So number one, the article calls on agreeing on common interests. So having protection for intellectual property rights, but also having separate rules and regulations on the book for public health interests, so that we're not just charging people who are committing these crimes with a 6 months house arrest and 5 years probation, right? There's a much different set of rules and regulations for people who are dealing in illicit narcotics and opioid trade. So that's a really, really good article if anyone's interested in reading it. Why is this happening though overall? As Jim mentioned earlier, this is really an issue of access to medications. We have many shortages here in the United States. I think last year alone it was over 200 unique shortages in the United States. And think about that on a global context. How many people have access to the HIV medications, to the tuberculosis medications, to the antiretrovirals that they need in a lot of developing countries? It's not there. And if it is there, what's the cost? How much are people spending on these different medications, both here as well as abroad? So when you think about it in a global context, this really creates an opportunity for crime. I'm going to skip over this slide in the sake of interest because I want to really get to these other points. Over 700,000 people a year die from falsified medications. That's equivalent to 4 jumbo jets going down every day, and we don't hear about it, or we hear very little about it. It's estimated that somewhere between 30 to 40% of medications in developing countries are falsified, and about 1% in the United States and other developing countries are falsified medications. So we do have this issue here as well as abroad. It's an issue that touches everyone. And I would say that, and I'm not trying to be political, but sometimes it's hard to separate politics and medicine, but the United States imports 80% of their raw material to make medications from other countries, primarily from China. 40% of the medications that we use that are already made are imported, primarily from China. If you start looking at the tariffs that we're putting in place, the access and the cost of medications isn't going to go down. We're going to be seeing, I think, more issues with falsified medications, more opportunities for this in the future. Counterfeit medications, the vast majority of them, just like the Avastin case, have no active ingredient. That can mean devastating consequences for a lot of people depending on what they're using. Think about HIV, AIDS medications, TB medications. So active ingredients, sometimes when I say that, they think, oh, well, no harm done. But in fact, it's just the opposite. There are many people and many organizations that are working on this, both here in the United States as well as globally, and you can see some of those listed here. But some of the main players globally are the WHO, the FIP, which is the International Pharmacy Federation, and the World Trade Organization, along with a lot of the big pharma companies, because it's their products and their names that are actually being taken through the ringer, I guess, for lack of a better word, because it's their medications that are on patents that are not working, that are falsified, and so people are looking at them and saying, we don't want to use these. But here we also have a lot of people that are working with them, and I have those listed here. I don't want to leave this on a down note, so I always like to tell people what you can do, and I know I have a lot of practitioners in the room and global health experts in the room. One thing that I always like to tell to tell providers is to make sure you're buying through legitimate supply chains. If you don't know who they are, call your pharmacist, call the call some of the state boards of pharmacy, or you can look online to some of the government agencies as well. You can check the FDA websites for frequently falsified medications. High-cost medications and popular medications are often part of that list. Destroy your packaging, vials, bottles, cardboard boxes, all of it. Make sure it's destroyed. And for your patients, make sure that you're talking to them about changes in tablets, sizes, shapes, color, hardness, softness. If they're experiencing no side effects or new side effects, these are all things that patients should be aware of, and this is what's recommended from the WHO as well as from our national pharmacy agent boards as well. So with that, I want to be conscious of people's time, so I'll turn it over to the next speaker.
Terrific.
Thank you.
Simultaneously terrific and terrifying all at the same time. Just what I thought you were going to do. Next, we're going to move on and shift gears a little bit to the idea of antimicrobial stewardship. And first up is Lina Elbadawi. She's a medical officer in the United States Public Health Service, and she's currently a career epidemiology field officer in the Office of Public Health Preparedness and Response at the Centers for Disease Control and Prevention, and she's assigned here to the Wisconsin Division of Health. I just got to meet her, and I'm really looking forward to hearing what she has to say.
Yeah. So I'm going to probably be more around 7-ish minutes. But thank you. I'm really happy to be here to talk to you about antibiotic misuse and overuse and the role of public health in antimicrobial stewardship. So I'm going to be using antibiotic and antimicrobial interchangeably. But before we begin, I want to define antimicrobial resistant bacteria, or AR bacteria. That's just simply bacteria that are resistant to antibiotics that are prescribed to kill the organism or prevent it from replicating and growing. So these are pretty serious public health infections, and they're pretty significant burden, estimated to be over 2 million illnesses and 23,000 deaths annually, and this is in the United States alone. And from an economic perspective, it costs the US healthcare system over $20 billion. Now, it goes without saying that these types of infections are more difficult to treat, and what that means is poor patient outcomes, so prolonged illness and death. So that's the problem. There are solutions, and part of those solutions are antimicrobial stewardship. And that really refers to a set of coordinated strategies looking at improving the use of antibiotic and antimicrobial medication. And the goal is really to enhance and improve patient health outcomes, as well as reduce resistance to antibiotics and cut out or decrease unnecessary costs. So simply put, that's really the idea of getting the right antibiotic to the right patient at the right time. So the goals of antimicrobial stewardship really fit well with the goals of public health, which is really about promoting health and prolonging life. And so part of this is really looking at surveillance and education. And by surveillance, we're not talking about necessarily nefarious or suspicious activity, but more the systematic collection of data for health information and action. So in this case, we're collecting antimicrobial prescribing and antimicrobial resistance. And we're pretty fortunate here in Wisconsin. We have an excellent public health laboratory, the Wisconsin State Laboratory of Hygiene, which has actually been doing antimicrobial susceptibility testing and antibiotic prescribing and resistance for quite a long time, since the late 1990s, when we first saw the emergence of multi-drug resistant salmonella outbreaks. And other parts in the state as well. Marshfield Clinic in the middle part of the state, since 1999, has been looking at antimicrobial prescribing and resistance and Streptococcus pneumoniae. And this really gave birth to WARN, or the Wisconsin Antibiotic Resistance Network, which I'll talk about a little bit later. In 2002, the State Lab of Hygiene joined NARMS, which is the National Antimicrobial Resistance Monitoring System. And this is really a nationwide public health surveillance system that's a partnership between Centers for Disease Control and Prevention, CDC, the FDA, the Food and Drug Administration, and the U.S. Department of Agriculture. And the idea is to, over time, map the trend in antimicrobial resistance in enteric bacteria, so basically gut flora or gut bugs, in ill patients, in retail meat, and in food animals. So jump a couple years forward, in 2010, Wisconsin becomes one of the first states to do carbapenem-resistant Enterobacteriaceae, or CRE, surveillance. Now, these are a group of bugs that, by definition, are multi-drug resistant organisms, or, as I mentioned, AR bacteria. And for them, their resistance is basically facilitated through plasmids, and you can think of those as mobile pieces of DNA that can jump from one organism to the next. And from a public health perspective, that's quite a threat, because this means that outbreaks and transmission can proliferate at a rapid rate. So moving forward to 2016, the State Lab of Hygiene becomes one of 7 regional laboratories as a reference lab for Antimicrobial Resistance Laboratory Network. And what that means is that they're at the front line of really detecting, containing, and responding to both innovative and more traditional multi-drug resistant organisms. And they do this by processing isolates from Wisconsin as well as 5 other states, including Ohio, Illinois, Indiana, Michigan, and Kentucky. And they do phenotypic as well as molecular testing, such as whole genome sequencing, to really predict kind of resistance mechanisms. Around the same time in 2016, the Wisconsin Division of Public Health, along with every local and state health department, was awarded funds from CDC to coordinate antimicrobial stewardship statewide, as well as continue surveillance. So in Wisconsin, this is largely done from the Healthcare Associated Infections Program, or the HAI program. And this program conducts HAI surveillance and coordinates HAI prevention with partners. Surveillance is mostly voluntary. And these are a few examples of some of the infections that we conduct surveillance on. And these are all reported through the National Healthcare Safety Network, which is the largest HAI tracking surveillance system run by the CDC. And you notice that Clostridium difficile infection, CDI, methicillin-resistant Staph aureus bacteremia, or MRSA, as well as not listed here, CREs, are also tracked, and these, by definition, would be multi-drug resistant organisms. So I'd briefly alluded to WARN, and I can't really talk about stewardship or antibiotics in general in the state without mentioning WARN. So it was established to educate the public as well as clinicians about appropriate antibiotic use for upper respiratory infections. It began in 1999 and received funding through the CDC from 2002 to 2007. And if you've seen any of the Get Smart campaign from CDC, a lot of that material was developed from WARN. So this slide is really looking at how we're viewing antimicrobial stewardship at the state level. So at the center, we have our antimicrobial stewardship steering committees, and this is divided up into several subcommittees that covers the continuum of human health. So we're really looking at inpatient, long-term care, emergency medicine and urgent care, surveillance, and in surveillance specifically, we're looking at statewide antibiograms for resistance, but we're also trying to encourage acute care hospitals to report into NHSN, that surveillance tracking system I mentioned, to track their antimicrobial use and their antimicrobial resistance. And in terms of the outpatient setting, there was a recent report that looked at antibiotics prescribed in the outpatient setting during 2014 state or nationwide, and there were over 266 million courses of antibiotics prescribed. So what that means is that there were 5 prescriptions written for every 6 people in the United States. And this represents about 80 to 90% of the total of antibiotics prescribed. Of course, there is variation by state and region. So the Midwest is slightly better than the South, but not much better than any other part of the country. In terms of the inappropriateness of outpatient prescription. About a third of antibiotics prescribed in the outpatient setting is inappropriate in that no antibiotics were required. And if you look at complete inappropriateness, which includes either the wrong dose or the wrong antibiotics, this approaches about 50% of inappropriate antibiotic use. The last subcommittee that I haven't really talked about, mainly because the OneHealth subcommittee, we were so focused on human health that we completely forgot about OneHealth. And it took an astute veterinarian who's also sitting here at the who pointed out the importance of OneHealth. So with that, I'll turn it over to Dr. Rachel Klos.
Thank you. Hopefully that gives you a little bit of context in trying to sort of understand about the global and local issues, because you can imagine, I mean, as we see more and more headlines about multi-drug resistant organisms worldwide, what it takes to do that surveillance. And in many ways, I think that every time I see one of those headlines, it's the tip of the iceberg of what's really out there. And I think we're fortunate in Wisconsin to live in one of the states that actually has one of the leading health departments. And so I think we know a lot more about what's going on here. It's still scary to see both how much work it needs to be done, as well as how much has already been done. And thinking about sort of how we're going to apply these things and transmit them globally is really one of the sort of daunting things to look for in the next 10 or 20 years. Sort of on the heels of that then, giving sort of the other piece of that, Rachel Klos is an infectious disease epidemiologist and, as Lina mentioned, a leading veterinarian as well. She's with the Wisconsin Department of Health Services in Public Health. She's responsible for enteric disease surveillance and conducting investigations of foodborne and waterborne disease outbreaks, as well as zoonotic and enteric disease investigations. She's a graduate from UW-Madison here in the veterinary school, as well as getting her MPH here, and she's been working at DHS for over 10 years, and I'm thrilled to have you along to share the OneHealth side of this, if I can figure out. Well, you're on the same slide deck, right? So I can almost not screw this up. Look at that.
Okay, so thank you for that introduction. So I actually wanted to start by showing this slide. This is the same slide that Lina previously provided, but she kind of held back a little bit. What she didn't say is that 1 in 5 antibiotic resistant infections is actually attributed to either food or consuming food or contact with animals. So as you can imagine, as a veterinarian and an infectious disease epidemiologist, this is a big concern, and unfortunately it's something that our program is dealing with on a routine basis. Now we're more focused on response, so Lina's program really is out there and trying to push a lot of the prevention messaging. In our program, unfortunately, we're doing a lot of the response work. So if you just look at the CDC Threat Report, this is from a few years back, they tried to prioritize what are the most important concerns in terms of antibiotic resistance, and you'll see 2 foodborne pathogens here, Salmonella and Campylobacter, are listed among the most concerning of the resistant organisms. And combined, these 2 agents alone account for about 2.5 million illnesses every year in the US. So if you can imagine, even if you have a small percentage of resistance, so for Salmonella it's estimated to be about 8% of infections, that's a significant number of illnesses. The other thing we know is not only are these foodborne, but the major reservoirs for these organisms are animals, and a lot of those are food producing but also companion animals. So Lina mentioned OneHealth. I just want to make sure we all sort of understand what that means. So OneHealth is sort of this philosophy that the health of people, animals, and the environment are all really interconnected. And I don't know that really anybody's going to argue with that statement, but I think the tricky piece about OneHealth and the challenge for all of us is trying to figure out how do we become actually practitioners of that, not just talk about it in theory, but when we're working on solving problems, are we actually working together across those sectors? And antibiotic stewardship is really probably a great example and an opportunity to really put OneHealth in place. If you're a veterinary medical practitioner or human medical practitioner, we all really have the same goal, right? We want to be good stewards of antibiotics so we have fewer of those infections to deal with, and we want to make sure that when we do need to go and pick an antibiotic, that there's an effective one that's out there. And I would like to say that I think the fact that our antibiotic resistance program now has a OneHealth subcommittee really sort of demonstrates that we're trying to move beyond just the talk and really putting some of that into action, so that OneHealth committee is really part of the team now. So just as stewardship is really being pushed in the human medical community, the same thing is true on veterinary medical side and as that relates to animal health and food production. Judicious use of antibiotics has really been important. And as many of you probably are aware of, so the subtherapeutic levels of antibiotics have been used in production medicine for quite some time to promote growth and for other production value. And some of those antibiotics were medically important or might be in the same class as medically important antibiotics. And now the FDA has banned their use for that specific type of growth promotion. And that's a big step. And then it doesn't mean that you can't use antibiotics in production animals anymore, food-producing animals. But when they do, they now have to be used under veterinary oversight. So this really puts veterinary medical professionals right in there, so to be really making sure that those medications, when they need to be used for treatment and prevention of illness, that they're being used appropriately. And not only is this just a regulation, but other, like the American Veterinary Medical Association and other animal health organizations have really embraced this idea of stewardship, just like you're seeing that on the human side of things. I'm going to skip that one for time. What I wanted to kind of point out here, so just as the stewardship program is really focusing on prevention, I wanted to briefly highlight outbreaks for a couple of reasons. So my program really is key on investigating outbreaks, and we investigate outbreaks not just to stop that immediate outbreak that's occurring, right? So we want to interrupt transmission. But outbreaks are really important because we learn a lot about disease transmission, contributing factors that led to that outbreak, and they also tend to highlight problems that are happening. So for infectious diseases, we might be working away, but it might take a big outbreak to get attention, right? And so they're real opportunities. So foodborne outbreaks, probably all of you, and I can really easily think about a variety of foodborne outbreaks that have been reported in the last several years caused by multi-drug resistant salmonella from consuming pork, beef, and chicken. And those are opportunities too. So what I've seen in the 10 years I've been doing this is that we used to focus a lot of the attention and interventions on making sure people cooked their food and they didn't cross-contaminate and that restaurants were using food appropriately. So really focused on that end user. And that's good, we need to do that. But what I've seen over time is this idea of OneHealth is we're starting to think a little bit more about pushing that upstream, what's happening in the processing. And now we're even getting to the point where we're starting to think about, well, what's happening on the farm? How are antibiotics being used on the farm? And maybe we can sort of make sure that we're looking at the entire continuum and not just saying, well, we'll make sure people cook their beef properly. And I think that's really important, and it sort of shows progress. I wanted to highlight this outbreak in particular. This is a multi-state, multi-drug resistant Salmonella Heidelberg outbreak, and it was detected in our state. It's now, we have cases in other states, and it's affecting both people and animals. And that's pretty unusual actually to have simultaneous outbreaks affecting animals and people at the same time. And we're really lucky that we were able to detect this because we have sort of a OneHealth culture in our state. So those of us who work at the health department, at the state lab of hygiene, and our veterinary diagnostic lab, we know each other, we talk to each other routinely. And so when this outbreak was occurring in cattle and in people, we were able to make that connection pretty quickly. So once the outbreak was detected, this slide is just to kind of give you an idea of what's been going on to try to work on it. So human health agencies, animal health agencies, regulatory, public health, private industry, this has really been a collaborative approach to trying to figure out what to do with this very drug-resistant organism. On the veterinary side of things, there are no antibiotics you can use in a food-producing animal to treat this infection. On the human health side, we have a couple left, but we have reduced susceptibility to ciprofloxacin, and basically azithromycin is our only choice left. So we have been recognizing that we needed that One Health approach to investigating this. So that means we need to make sure physicians know what's going on, so that's the role of public health agencies. The animal health agencies can work with producers and connect with industry. Our veterinary diagnostic lab is working to make sure there's information going out to farms and veterinarians about this organism. So it's been a really, I think, good example of how One Health can work. None of those agencies can ever tackle this problem alone, and so this has been hopefully a good practice for us moving forward. Just wanted to also mention, just so no one thinks that it's only an issue of food-producing animals or companion animals, we've been also investigating an outbreak related to puppies and a multi-drug resistant Campylobacter strain. So this has been found in people and puppies. So it's not just those food production animals that we are also working to improve stewardship for. So sort of just kind of closing comments about One Health. I think, you know, in the last 10 years, I can see that there's been, the trend is the correct way. We are working together more, and that's routinely happening. I think the will is there. I would say the one thing that's still difficult is our funding streams are so different and separate still. And so sometimes that can be a little bit of a barrier to getting done what we would like to do in collaboration. But I'm optimistic that it seems like we are moving in the correct direction. And so hopefully that's all end with a good note in terms of One Health.
That's terrific, Rachel. And as a pediatric infectious disease physician, while I see a lot of job security in the future for me, I'm also relieved that we're really starting to make some movement. One of the things that's really reassuring is seeing this sort of interdisciplinary approach and seeing how people kind of come together around these common issues. And I think Wisconsin and UW are really kind of leads in that. I've been really privileged to be part of these One Health groups as the human physician representative from the group that the Wisconsin Veterinary Medical Association has convened, where we're starting to talk about not only foodborne and disease transmission, but all sorts of other opportunities where human and animals and humans interact and share diseases. And I think there's a lot of really interesting work that can be done. And again, it's a model that you can see how hard it is in some countries or some regions of the country to get people to come together like this. But this is really what we're trying to promote as the Global Health Institute, is trying to get people from different disciplines that have common goals to work together and really try to transgress these barriers between them. All right, we're going to change gears then and switch over to the dreaded opiate issue that we've all been hearing so much about. Dr. Martha Maurer is a social scientist who's currently a health policy research scientist with the Sonderegger Research Center at the School of Pharmacy. She's got a nice long bio that I'll shorten in the interest of time, but she's got a lot of focuses that kind of bring a lot of this together, including looking at pharmaceutical supply chains and healthcare in professional practices, but also looking at the role of pharmacists and working in communities and educating people about proper disposal of medications. She just joined the research center this year, and she actually was with the Pain and Policy Group, which is why she can sort of speak to both the access issue around opiates as well as the issues of control, because she's sort of seen it from the Carbone Cancer Center side with Jim Cleary and his group, as well as looking at people living with all sorts of disorders that require pain medication and pain management. And she actually co-directed the Policy Research and Training Program and the International Pain and Policy Fellowship. So she can really speak to these things from both sides. So Martha, it's a pleasure to have you, and take it away.
Thank you so much. It's great to be here and to be part of this panel. So I think we're all familiar with the opioid crisis here in the US, but really what I want to do with this presentation is give a bit of a context of what's happening globally, not only related to the misuse and abuse of opioid medications, but also to the lack of access and availability in many countries around the world. So first, I just thought I'd do a quick review of some of the clinical uses of opioid medicines. Many of us are familiar with their use for pain management, but you can see there are many different types of pain that they're used for around the world. And another common use for opioid medicines is for medication-assisted treatment for opioid addiction or opioid use disorder. And those are mostly with methadone and buprenorphine. So just to give you a sense of what the global consumption of opioid medications has been over the last 35 years, this graph shows 5 of the most commonly used opioids to treat pain globally. They're in morphine equivalents, so the trends are comparable. And the pink trend line shows the total of these 5 opioids. And I just wanted to point out a few of the trends. You can see that there's been a dramatic increase over the last 35 years in the total. But if you look at the red trend line, that's morphine, which we know is commonly used to treat cancer pain and in the context of palliative care. And you can see that morphine started to increase in the mid-1980s. And that was, we think, because that was when the World Health Organization issued some seminal cancer pain guidelines recommending morphine as a first-line treatment for cancer pain and palliative care. So you can see it start to increase. And then in the mid-1990s, though, you see oxycodone and fentanyl starting to increase quite rapidly. And they surpassed morphine in the late 1990s and continue to increase, again, quite rapidly over the years. And today they are the 2 most consumed opioids of these 5. And you can see, though, interestingly, oxycodone is starting to decrease in the last several years. And again, this is a global average. But now to look at what the differences are among regions of the world and among countries, there are great disparities. This is a map of opioid consumption as a function of the need for palliative care. And this represents the same 5 opioids as the previous slide in morphine equivalents, and they're in aggregate. So you can tell by the size of the country, the larger the country, the higher the consumption. So clearly, the highest consumption is in Canada, the United States, Australia, and parts of Western Europe. Whereas, in contrast, many regions of the world, South America, Africa, and most of Asia are nearly non-existent relative to the other parts of the world. And this holds true, too, if we look at it in terms of income level. So low and middle income countries represent roughly 80% of the world's population, yet they consume only 10% of the total opioids each year. So why is this the case? This is a survey that was done by the United Nations International Narcotics Control Board. They surveyed drug control authorities from countries all around the world, and these were some of the responses from the survey. They were identifying the barriers in their own countries. They identified concerns about addiction, which probably is not surprising. I'd also like to highlight the insufficient training for healthcare professionals. So similar to the United States, most countries around the world have very little training for prescribers on how to use these medications. So prescribers aren't using them because they don't have very many in supply, so therefore they're not demanding them and the country doesn't increase the supply. So it creates a cycle of sort of low supply all around the world. I also want to mention laws and regulations that was also identified as a main barrier. So some countries have very, very restrictive policies and administrative practices around prescribing opioid medications. I was in the country of Georgia several years ago, and in Georgia, this is still the case today, outpatients who are prescribed an opioid need to pick up their opioid in a police station. And the police station, it's only during designated hours, and it's only on 2 days of the week. So there is a global call, there has been, to improve this problem. The World Health Organization, certainly for many years, has encouraged governments to address. United Nations regulatory bodies have also called on governments to identify these barriers in their countries' administrative practices and policies and try to address them. to increase the appropriate use of these medications, as well as many professional organizations, non-governmental organizations, and most recently, the Lancet journal hosted a commission on pain and palliative care. And again, they issued a report recommending that countries look at their barriers in this area and try to address them as they can. So now I'm going to just switch over in the interest of time to the misuse of opioid medications and to give you a sense of what's happening outside of the US. So the highest levels of opioid medication misuse are, not surprisingly, in the US, Canada to some extent, as well as Australia. In more recent years, there's emerging indications of opioid medication misuse increasing in Europe, and I'll describe that a bit more in a moment. I also recently read that there are reports of the opioid tramadol being misused in parts of Africa and Asia. However, it's unclear whether this may be a counterfeit medication version of tramadol. They're not quite sure yet. But I just also want to point out that when we're talking about misuse of opioid medications, it's hard to compare across countries because countries use different metrics to measure the opioid abuse. Sometimes they include heroin. In the toxicology reports, they measure things differently, so it's very challenging to make comparisons. So Europe, again, I just wanted to mention because this is an emerging issue. Historically, heroin has been the primary opioid that's abused throughout Europe, and it still is today. However, in more recent years, they've been seeing that synthetic opioids such as buprenorphine, fentanyl, and methadone are increasingly being misused. And some experts are suggesting that this may be because heroin, beginning in, I believe it was the early 2000s, is becoming less and less available for people to misuse. And there's an increase in treatment programs using methadone and buprenorphine. So there's more access to those medications, and so they think there may be a connection there. So why is this happening? In 2014, an addiction specialist from Canada, he and his colleagues wrote a thought piece or a commentary where they compared what's happening in North America, the US and Canada, with what's happening in Europe, trying to see why are we having these problems in North America but not as much in Europe. Again, this was a few years ago. And these were the factors that they hypothesized might be contributing to it. So just the fact that the consumption is higher in the US and Canada compared with the rest of the world, so there are more medications sort of in the system vulnerable to diversion and abuse. Differences in the healthcare system. So in Europe, there tends to be stronger regulations on who can prescribe, what types of practitioners can prescribe, and for what indications compared with the US and Canada. They also mentioned the idea of the culture of sort of perhaps the overuse of medications for treating certain diseases and in the US and Canada compared with Europe, where that's not as much of the culture of medicine. They also talked about patient expectations perhaps being different in US and Canada. And finally, the idea of the structure of the healthcare system as being more focused on profits in the US and Canada, which would be an incentive for the physician to increase patient satisfaction and perhaps sort of reduce the amount of time they need to spend with a patient and choose to prescribe a medication versus trying alternative therapies, perhaps. So again, these were just hypotheses. They did not test these, or they were not based on an extensive literature review, but just some food for thought as this problem is emerging around the world. So finally, just very quickly, I wanted to mention, these are two graphs from the United Nations Office on Drugs and Crime, and they represent the same countries. The top graph is the use of opioids as medications, and the bottom graph is the abuse. And so they published this in a report of theirs several years ago, and they wanted to make the point that just because a country has a high level of consumption that doesn't necessarily always correspond to having a high level of misuse or abuse in that country. And sometimes the opposite is true. There are countries, I believe Nigeria, that has relatively low consumption. However, on this particular measure of abuse, they had a relatively higher measure of abuse and misuse. So, but again, I want to caution the point I made earlier about data, because really these are very different ways of measuring the problem in each country. And so this is just sort of a snapshot of what was occurring at the time. So really my point is that what really needs to happen is we need to develop better data, not only in other countries, but as well as here in the US, to be able to describe the problem and then address it appropriately. Thank you.
Really terrific, really a great overview, and actually I have a little bit more insight into where we are and why we are where we are. So this is the time in our game show where you get to play along. So we can open it up for questions. Anne's got a microphone over there. I'll start out just by asking both Trisha and Rachel, how big a problem is counterfeit medications in the veterinary world? Is that as much or more of a problem than what we see in the human side of things?
I don't know the answer to that.
I mean, it's one of those things. Is it a big issue?
Yeah, I don't have the...
You don't, data's not required. It was out of left field. But.
I don't have the data. I don't think this is on. I'll just yell. I don't have the actual statistics on it, but yes, there are certainly issues with counterfeit, falsified medications in veterinary medicine as well, and vaccines. So in both human and animals. So it certainly is an issue.
Right.
Just a very quick question for Dr. Maurer. I was wondering, I heard in the United States that a lot of the opioids are coming through dentists. And I wondered if your study looked at dentists or just the medical, or if you have any thoughts about that.
Yeah, I certainly know, I'm not sure if this is on it, that's the case in the United States, that prescribing for dental pain is contributing to the problem. I don't know what the situation is globally, though. I'm not sure.
I mean, dental care is certainly an unmet need in so many areas, and it is an interesting correlation, maybe.
Yeah, an explanation that I've heard for increased usage in the case of heroin, at least, is that higher qualities of it have become available now than traditionally, thus making it possible to, I guess, ingest it nasally or by smoking it, which is probably more palatable than injecting it directly into a vein. So to what extent do you think that's more responsible for the, I guess, reappearance of heroin again? Thanks.
That could be part of it. You're speaking about the U.S. right now, or just or globally?
Well, primarily the U.S.
In the U.S., yeah. Yeah, that very well could be. I honestly don't know I haven't read up on the situation in the U.S. as much regarding the heroin coming back, so I'm not sure, but I think that's certainly been posited as one reason.
Dr. Patz?
I have a question for Rachel. Regarding use of antibiotics for agriculture, the idea of as a growth promoter and using antibiotics, but now there are more and more studies, especially out of the Scandinavian countries, that going completely without any antibiotics, you can actually grow meat quite well. And I'm wondering, have we advanced in agriculture, and are there any trends, positive trends, as far as less antibiotics in animal feed?
In the U.S., you mean particularly, or?
Sure, U.S., wherever you have a good case study.
Sure.
But U.S.
I mean, I think in the U.S. it's gonna, there is evidence that you don't have to have it, potentially, but I think it's been used a lot here up until now, and so I think that's gonna be a gradual change. The veterinary feed directive is sort of gonna remove some of those opportunities, and I think that'll force innovation into other production methodologies that will also help with our animal husbandry, and hopefully there will be other ways to have good growth without use of medications. Because I think innovation is driven by need, right? So if you can't use those, you find other options. And I think getting back to biosecurity and husbandry are going to be the keys for a lot of that. But again, that's not my area of expertise, so.
I had a question about the opiates misuse. I think there have been a number of articles coming out recently about Purdue and the effect of marketing and kickbacks and the correlation between Purdue's fraudulent marketing in particular. I think they spent like $500 million to pay off those settlements, right? So I'm curious if we've looked at how pharmaceutical companies have been marketing in the US versus abroad to account for some of those differentials in overprescribing leading to abuse.
So our group has not looked at that specifically. However, I believe it was a number of years ago, there was an extensive series of articles in the LA Times and one of them focused on sort of the transition from some of the marketing practices focusing on the US to now focusing on other countries. So there are some people who are looking into that and writing about it. So it may be the case.
I have a question for Dr. Klos. So in Wisconsin, we've gone from 4 concentrated agricultural feeding operations, CAFOs, to over 400 in less than 10 years. And you mentioned that it's required to have a veterinarian give antibiotics, but my understanding is in Wisconsin, there's no requirement for the farms to report actually what they're doing and what antibiotics they're using. So my question, I mean, the idea of OneHealth is really, fabulous, but how will we ever know if we don't know what's going on in the farms? And is there any move towards regulation so that we actually do have transparency about what's going on in terms of antibiotic use in agriculture?
I mean, it's really kind of stretching what my area of expertise is. I'm an epidemiologist. I would say we don't require physicians to report to the government every time they use an antibiotic. So, I mean, veterinarians really have embraced this idea. They want to be involved in prescribing medications. They're not going to be as available, so you really have to have veterinary oversight if you need to use or want to use one of these medications. Is there going to be a point where we're going to regulate it so that every time one is prescribed, it's getting reported somewhere? I doubt that will happen.
Well, you raise an interesting point, though, because although we, as a human physician, we don't self-report, they know everything that we're doing. And it's amazing what the pharmaceutical industry knows about our prescribing practice because of how they buy information from the pharmacies. And it is interesting that, that's been sort of a gap, I think, in a lot of other prescribing behavior in veterinary and others, is that, we're not required, but they've figured out a way to do it from a business standpoint, and whether that becomes part of this. But you both raised an interesting thing that I wanted to ask the whole panel, which is, we've all kind of skirted around and talked a little bit about the role of government and regulation and all of this kind of stuff. Obviously in Wisconsin and most other states now, opiate prescribing is now heavily regulated, and so each and every prescription any of us writes has to go through a number of hoops before it can be even approved, and it's all in a database, so they know exactly who's prescribing what to who. Do you see a role for that same kind of regulation and oversight for antibiotic use or for the acquisition of medications from suppliers? I mean, do we need to think about going to that degree, both from a U.S. and then maybe even a global side?
Well, from the antibiotic side, we kind of already do that. I'll try to project. So from the antibiotic side, we kind of already do that in the sense that hospitals are dinged if patients develop healthcare-associated infections. And a lot of times the risk of developing these infections are lapses in infection control as well as inappropriate use of antibiotics. And so the ding is that they're not going to get compensated or reimbursed by CMS. So, and I know, well, a couple years ago, CMS was talking about how they're going to make antimicrobial stewardship in the acute care setting as something part of meaningful use. And so I expect that will come down the pipeline, at least on the human side. Now on the veterinary side, there isn't a CMS equivalent that could really tie dollars to that kind of, to incentivize it in that way.
Right.
So.
Interesting.
So it's almost like reverse regulation. You're regulating sort of the back end.
Yeah.
Right, you're regulating the outcome and sort of backing into
So
it.
you're forcing innovation.
Right. I mean, it is interesting, though, because for a lot of us that are involved in infection control type activities, trying to get support from hospital administration was always challenging until suddenly there was the risk they weren't going to get $10 million in Medicare money if our rates of infections were higher than they should be, and all of a sudden they cared. So, I mean, unfortunately, you know, when you talk about regulating and monitoring this kind of stuff, you know, the one part is the government regulation, but the other part is it a carrot or a stick? And money talks. And so I think figuring out a way that there might be a financial incentive on the veterinary side might be an interesting tactic to try to get some control over it.
Well, and I think there are things maybe a little bit similar in terms of veterinary medicine. So if you think about a dairy that, let's say, has to treat an animal, there are certain withdrawal periods that are required. If you're going to use an antibiotic, you can't, let's say, put that milk into the milk supply, or that animal can't go to slaughter. And they do test. So they look for residues that would suggest there's an antibiotic being used and that withdrawal period. Now, it doesn't necessarily measure whether it was used appropriately, but there are ways, those dairies are penalized if there's residue in their milk, if there's residue, that meat is condemned. And so certainly concerns with residue has prompted innovation already in terms of, like, there's a program called Food Armor. It's run out of the Wisconsin Veterinary Medical Association. It was trying to get at issues of too many positive residues, and working with farmers to identify how can we have better on-farm protocols so that we're using antibiotics appropriately, hopefully using less of them, and actually it's hopefully improving their economics. Because if you're not using so many antibiotics, maybe that means you have less costs going into that. So it's not quite the same as having CMS behind you, but there are some sort of market-driven factors that could help.
No, but that's a great answer. I mean, that there is a financial disincentive to over-medicating your animals if it means that your end product that you're trying to get out there isn't allowed to be released into the marketplace. So it all comes down to money.
Hi, I had one for Trisha. Hi, for Trisha.
Yes.
So I'm curious to know who are the key players in the vigilance for counterfeit medication in the United States. I know in developing countries, it's usually the community pharmacists, but kind of the imitation there is very obvious compared to the drugs we see in our counterfeit medication in the U.S.
So I'm going to repeat the question to make sure I heard it correctly, because it's a little hard to hear up
Yeah, it's
here.
echoey up here.
So I think the question is, who are the primary people who are overseeing the vigilance of these falsified counterfeit medications, both here and abroad?
I'm just here.
Just here, okay.
Yeah.
So, and this gets a little bit to the question that was just asked about oversight of government regulation here in the United States. As of 2013, President Obama did sign into law a new law that basically is requiring manufacturers to put in different track and trace systems. That needs to be, it's being implemented and rolled out over the next several years and should be finalized in 2023. So these include things like barcoding and tracking and trace of individual packaging from the manufacturer to the point of receipt. There's a lot of questions with this because that too can be counterfeited. So there are questions about how to get around this. There are different manufacturers on some of the higher cost medications are putting in specific chemical substances that don't affect people, but they are unique signatures to that medication, so they can be looked at on assay and so forth. And there's also some radio frequency technology that's being used, may be used here in the United States. But again, this is a law being put into place, started in 2015, ending in 2023, but it's really upon the manufacturer to decide what type of protocols they're going to put in place for their particular medication. The law didn't say that you have to use X, Y, and Z. It's up to the manufacturer to see the need and then to decide what kind of tracing they want to do.
All right, I think we're going to
ask one. I just have a quick question, and that's all of us have, or many of us have worked places where we see that people can go into pharmacies without a prescription and buy a single pill, a single antibiotic dose, because that's maybe all the money that the person has. And so we know that short course antibiotics are not enough course, increases the risk of antibiotic resistance, not to mention that people may be taking antibiotics for a viral illness or something. Right. It's not going to work. What's the World Health Organization or other international organizations doing about trying to change how pharmacies are able to give out medication worldwide, other places?
So I'll answer that to the best of my ability, but I appreciate other people hopping in. So the interesting thing about pharmacy, and I have a colleague in the room that could also probably speak to this, is that pharmacies around the world don't look like pharmacy here. Many countries, there's not necessarily an FDA or equivalent oversight. So in many countries, the pharmacies that you see aren't, it's a storefront with not an actual trained person working there. So the laws and regulations that are in place in some other countries are non-existent. Most of the time in Europe where you can go in, turn in your prescription, specifically in Spain, I'm most familiar with that, when you turn in the prescription, or I'm sorry, when you buy an antibiotic, the pharmacy there actually has to write a prescription and turn it into their local physician for oversight and review because it's all reimbursed through the government. So they do have different strategies in place to have a double check on what's being dispensed without that prescription in hand. As far as what the World Health Organization is doing, they of course have antimicrobial stewardship guidelines out. Those are mostly for inpatient use at this time. Antimicrobial stewardship for the outpatient setting isn't necessarily in place yet, but I think we're moving towards that. We're having a lot more discussions about appropriate use, primarily again because this talks to reimbursement from hospitals for, you know, what's that 30-day readmission rates when people are getting brought back in? Are they being prescribed appropriate antibiotics? Are they getting side effects from those antibiotics, bringing them back in within that 30 days? Because that's a ding, again, with CMS. So I think there's room for improvement, I guess is the short answer. I think that the WHO certainly has good guidelines set in place for antimicrobial stewardship. Outpatient is still, there's room for improvement there.
Nationally, the CDC has really good guidelines for pretty much all spectrums of healthcare, including outpatient, long-term care, nursing homes. And someone mentioned dentists. A lot of studies have recently shown in outpatient prescribing, they're also a big culprit for inappropriate antibiotic use. And a lot of it is just because, not to beat up on dentists, it's just a lot of it is there's a lot of updating of guidelines and folks aren't keeping track of that, so.
All right, I think we're going to leave it there. I think it's amazing to think about all these guidelines that are being developed, but then the implementation, I think, is the challenge for everybody. And I think that all of us in this room are trying to work with various organizations that are going to try to help groups wherever they are then implement and actually make those guidelines come to fruition. So please join me in thanking our fabulous panel.